Okay, perfect. So today we're going to be talking about the 2020 coronavirus pandemic, the pandemic that we're currently on the downward slope of, some of the therapeutic options that we have, whether those are still viable or not, and then some med safety strategies when dealing with pandemics in general. Of note, I do not have any financial interest to disclose, nothing to make known. For pharmacists today, we would like to describe the life cycle of single-stranded RNA viruses. There are multiple types of those viruses. Recall some of the possible mechanisms of action. So for one of the medications that we have used pretty frequently, hydroxychloroquine in SARS-CoV-2 infections. Look at the black box warnings for the medication tocilizumab. Recognize safety issues for some other medications that we commonly do see used in SARS-CoV-2 infections. And then talk about the rationale behind social distancing and what that means in regards to the United States economy and the United States healthcare system. For technicians tonight, we would like to describe the life cycle of single-stranded RNA viruses again, talk about the difference between antigenic shift and antigenic drift. These terms both have to do with viral mutations. Identify the correct way to put on and remove gloves and masks for reducing viral transmission. Recall the differences between cloth, surgical, and N95 masks, and then describe the rationale behind social distancing again in regards to the United States healthcare system. So to get started, a quick overview. Coronavirus, as everybody knows, is a virus that is currently in a worldwide global pandemic. In late 2019, this coronavirus appeared in a cluster of pneumonia cases that developed in Wuhan, China. The virus since then has rapidly spread, causing more than 80,000 infections in China alone. And at this point, it's spread to every continent in the globe, with the exception of Antarctica. Listed here on the right-hand side, we have an actual picture of the coronavirus. This is taken using an electron micrograph. The coronavirus is shown in green, and infected cells, viral cells specifically, are shown in blue right over here. Some of the epidemiology. The outbreak of this coronavirus was first reported on December 31st of 2019 in Wuhan, China. Many early cases of the coronavirus were linked to the Huanan market in Wuhan, China. Again, coronaviruses typically replicate long-term in a host species at a constant rate. For example, there were 2 coronavirus outbreaks previous to this one. The SARS outbreak was in 2002, and the MERS outbreak was in 2012. The host reservoir species for SARS was in bat populations, and for MERS was in camels. Many Malayan pangolins and bats often have many coronavirus species that are similar in genetic makeup to the current coronavirus, SARS-CoV-2, and again, in that genetic makeup. So it's thought that the coronaviruses that may be in bats cause GI disturbances, which may have been transmitted through the Huanan market in Wuhan through fecal-oral transmission. The virus is transmitted person to person. It is transmitted through respiratory droplets. These respiratory droplets need to have direct contact with a mucous membrane, and that's important. The droplets, whether large or small, can travel about 6 feet from person to person, and that's important. It's going to become really important when we talk about social distancing and the rationale behind the distance we need to stay between each other. I have a video here real quick to display the ease with which respiratory droplets can move from person to person. So 6 feet may not seem like very much space, but if you actually were able to visualize what it looks like when somebody sneezes, respiratory droplets can travel quite a distance before infecting somebody or coming in contact with other mucous membranes. Now, it's important that from the data to date, this virus is not aerosolized. Again, we may receive more data in the future, but at this point in time, we do not believe that the virus is transmitted through aerosolized droplets. Some reports have detected this virus in blood and stool specimens of infected patients, but according to the World Health Organization, there have been no reports of fecal-oral transmission to date, and it's not thought that fecal-oral transmission is going to play a large role in the transmission of this virus. It is mainly through respiratory droplets. So we're looking at our US hospitalizations. This graph is extremely busy, so I'm going to try and break it up for us. We have underlying conditions and symptoms that we are going to be looking at when patients present. I'd like to first focus on the symptoms that patients are presenting to the hospital with. As you can see, over 80% of our population that is going to be hospitalized is going to present with a cough, fever, chills, and shortness of breath. We get into a few lower numbers here when we're talking about myalgia, diarrhea, nausea, and vomiting. but the majority of patients are going to have these three symptoms: cough, fever, and shortness of breath. A lot of these patients do have underlying conditions as well. About 90% of people do have some underlying condition. A majority of these patients do have an underlying condition of hypertension, obesity, or some underlying cardiovascular disease history. So that's important when we're looking at the disease mortality. These populations do seem to be somewhat more susceptible to the virus and disease progression. Again, when looking at US hospitalizations, I think it's important to look at laboratory findings and some of those lab findings that we may see in our patients when they come into the hospital. For white cell count, we do see a leukopenia, and often this is under about 5 for their white blood cell count. We do see a CRP that is elevated, a procalcitonin that is low, under 0.5. There can be increases in AST and ALP. And then D-dimer is also going to be elevated, as we have seen in a good majority of the patients that are infected with SARS-CoV-2. When looking at our SARS-CoV-2 infections, another thing to consider is the age of the patient population that is becoming infected with this virus. As you can see here in the graph from the CDC, this looks at the hospital admission rate by age of patient. And so as age increases, there is quite an increase in the number of cases. And those in an elderly population, specifically over 85 years old, are at the highest risk of becoming hospitalized if they are infected with the virus. In this graph here, I would like to talk about the differences between hospitalization, ICU admission, and then case fatality for this virus as well. So first, I'd like to look at hospitalization. Again, notice in our youngest population from 0 to 19 years of age, we do have the lowest rate of hospitalization, maxing out at about 2.5% of these patients being hospitalized. In those over 85 years of age, we can see up to 70.3% of these patients that are infected with the virus needing to be hospitalized. So again, those elderly populations do see the most complications from this virus. Next, I'd like to look at the case fatality. Again, in our younger population from 0 to 19, we don't see any fatality. In the 20 to 44, we see very low mortality as well. In our patients over 85 years old, that is where we see our highest mortality, with about 27.3% at a maximum of these patients succumbing to the disease. Now, something I think is very important here is to look at the total number of patients that are included in this information. Now, again, this information was taken from the CDC, but the total number is only about 2,500 patients. As we know, in the United States now, there are near 1 million patients that currently have the virus, and so this is a gross underestimation of what we do see in the United States. This information is from February 12th to March 16th, 2020. This, unfortunately, was the last date that this data was released from the CDC. It has been about a month since they posted this hospitalization data, and so hopefully we'll get some updated data on these amounts soon. But at this point, this is the best information we have, and so it is possible that these numbers have changed quite drastically over the last month. So as of today, I pulled these numbers from various sites to give us an idea of what is happening with the coronavirus right now. So globally, we have over 3 million cases, and nearly 1 million of those cases have recovered. In New York State, we have a total confirmed case count of about 300,000, with about 57,000 of those being hospitalized. That's around 16.9% of the confirmed cases that we know of that are being hospitalized here in New York State. In Suffolk County, we do have a little bit less amount, with about 32,000 people with confirmed cases of SARS-CoV-2. I'd like to draw your attention over here to these graphs real quick too. As you can see, these graphs are updated to the date. Our numbers of COVID positive infections are still increasing in New York State. This orange sliver right here is actually what represents Suffolk County specifically, whereas the pink represents New York City. And so we are still seeing gross increases in total numbers of COVID infections. But the graph down here shows us our new cases by date. And as you can see, the number of new cases has been going down. And so in this regard, we have reached our peak here with the SARS-CoV-2 virus. All right, and so I wanted to include this. This is a comparison of the SARS-CoV-2 virus with the seasonal influenza virus. And so a lot of people were curious about this comparison. Right here, when we talk about genetic makeup, we have a positive sense single-strand RNA versus negative sense single-strand RNA. And so these are very different viruses. I'll get into a little bit later about what a positive versus negative sense single-strand RNA virus means and how they replicate, but they are different as far as genetic makeup. Next, they are both transmitted through respiratory droplets. And this is going to be our first pop quiz. How far can respiratory droplets travel from an infected person? Perfect. And so the answer here is going to be B. So again, an infected or a respiratory droplet can travel about 6 feet from an infected person. And this again becomes important later down the road when we are talking about social distancing. And so it's really important to keep that 6 feet number in your head. So again, these are both spread through respiratory droplets. The SARS-CoV-2 virus does have about a 5-day post-infection incubation period, so many people are not going to start showing symptoms until about day 5, whereas the seasonal influenza virus only incubates for about 2 days, and so you do start feeling those symptoms a little bit sooner. When we're talking about symptoms specifically, they are pretty similar between SARS-CoV-2 and seasonal influenza. Many people have fever, dry cough, fatigue, or aches. Where SARS-CoV-2 is a little bit unique is that it has shortness of breath and a loss of taste that many people notice. Whereas the seasonal influenza typically has the fever, the cough, maybe a sore throat and some nausea, but no shortness of breath associated with that. The contagious period for the SARS-CoV-2 virus is about 2 to 3 days prior to the symptom onset. And this is extremely important at this point right here. And so at 2 to 3 days prior to symptom onset, that is why this virus is so contagious, because people can transmit the virus unknowing that they actually have it and have been infected themselves. And if you think about the number of people that you run into on any given day, that's quite a few people that you can transmit that virus to if you're speaking to them without a mask on. Now, the seasonal influenza virus is a little bit different. You can still transmit the virus before your symptom onset, but it's only about 1 day prior to symptom onset. Mortality, again, this information may vary based on age and location, and then this also may have been updated since the numbers in the United States have increased, but the mortality for the SARS-CoV-2 virus overall is somewhere around 2.9%. There's about a 0.1% mortality for the seasonal influenza virus. Now, the biggest difference here, I think, is in the risk of infection. The risk of infection for this coronavirus, the CDC actually estimates that most of the US population has or will be exposed to this virus. And that's nearly everybody. Whereas when we're looking at the seasonal influenza virus, the CDC reports that each year it's only about 8% of the population that is exposed to the influenza virus. So there's a drastic difference in the number of people that are going to be exposed to this virus. All right, and so our next question for the night, which of the following are the coronavirus responsible for the 2020 pandemic? We have 1, 2, 3, or 4. And so I heard from across the room here in the resident office that there may be some confusion. But right now, this is above in the red here, we have our standard laboratory respiratory viral panel. So this standard laboratory panel does test for quite a few viruses, but it does not test for the coronavirus. And so there was no correct answer here. It is not 1, 2, 3, or 4. But the SARS-CoV-2 virus is going to be found in a different portion of Power Chart when you're looking through. It's not in the typical respiratory viral panel. It's going to be found either under molecular genetics, or sometimes there's a reference lab tab as well that the SARS-CoV-2 virus can be found. But it's typically going to be labeled in some fashion with SARS-CoV-2, and that's what you're going to be looking for when you're looking at your patients to decide if they have been tested positive or negative for coronavirus. All right, and so as we just saw in our respiratory panel that we typically pull here at Stony Brook University, there are quite a lot of coronaviruses. This is because there are quite a lot of viruses in general. So I'd like to simply just mention some of the virus types that are out there. First, I'd like to talk about negative sense single-strand RNA viruses. These include viruses such as influenza, hantavirus is over here, and mumps, measles, parainfluenza, and respiratory syncytial virus, as well as Ebola, which is this long one down here, or the family of Ebola is this long one down here. The next class is going to be our single-stranded positive sense RNA virus. This is going to be diseases such as foot and mouth disease of cattle, hepatitis C, and then rubella as well. And then there are double-stranded RNA viruses. I'm not going to talk as much about these during this presentation, but they do exist. And this would include viruses such as the Colorado tick fever or Powassan virus. The coronavirus is a type of positive sense single-strand RNA virus, and this is part of the family Coronaviridae, but it's going to be really important here when we talk about viral life cycle that this is a positive sense RNA virus, and that it is very different from the influenza viruses that are in Orthomyxoviridae. So which type of virus is SARS-CoV-2? Perfect. And so it is D. Again, SARS-CoV-2 is a positive sense single-stranded RNA virus. And I know we had just gone over that, but it is fairly important when we're looking at the viral life cycle to understand which type of virus this is. And so now I'd like to talk about those viral life cycles and explain some of the differences between a negative sense single-strand RNA virus and a positive sense single-strand RNA virus. So at this point, it's going to get a little scientific. We're going to get into the nitty-gritty of how viruses are replicating. It's really important to remember when we're going through the viral replication that there are really two main functions of every virus. Viruses don't care about their pathology or their disease severity and what they're doing to their hosts. They only care about two things. And so a virus needs to create viral proteins and replicate. And anything other than that, it does not really matter to the virus. Infectivity matters somewhat in how the virus will spread, but once it gets into a cell, there are two things on its mind, just creating proteins and replicating. It's also important to recognize that in the cell, a positive sense RNA is equivalent to mRNA. So in our DNA, DNA is transcribed into mRNA, and then our host ribosomes can use mRNA to create that genetic material into proteins. And so a positive sense RNA, such as the coronavirus, is equivalent to an mRNA and can be used by those host ribosomes directly. It's also important to mention some viral enzymes at this point. Some of the enzymes that we're going to be looking at, the main one really is going to be RNA-dependent RNA polymerase. And this viral enzyme is going to be extremely important in the replication of the virus. So we're going to look first at a negative sense single-stranded RNA virus and how it is, and how they get into the cell and replicate. So once the virus is outside of the cell and binds to the cell and fuses, we now have a negative sense single strand of RNA inside of the cell. There are really two strands of DNA and RNA both, and that's what forms that helical structure. There's a positive strand and a negative strand. Now to create one, you need to have the other so that an enzyme such as RNA-dependent RNA polymerase can create a mirror image of that RNA. And so if you have a negative sense, you can only create a positive sense. And if you have a positive sense, you can only create a negative sense and vice versa through the enzyme RNA-dependent RNA polymerase. So the enzyme again that's going to make that creation is that RNA-dependent RNA polymerase. But our body does not have RNA-dependent RNA polymerase. That's because we only create mRNA from our DNA. The mRNA or messenger DNA is sent directly to the ribosomes where we can create proteins. There's no need for us to create a negative strand of DNA or of RNA at any point in the cycle. So we don't have this RNA-dependent RNA polymerase alive typically within our cells. So it's really important that this virus brings in its own copies of RNA-dependent RNA polymerase. As you can see in the outside viral copy, there are these little proteins shown in pink, and then these proteins are brought into the cell. Once these proteins are, or these enzymes are inside of the cell, this negative sense single-stranded RNA can then be translated into a positive sense RNA on both sides here. This positive sense, as we mentioned before, is exactly like messenger RNA and can be used directly by our host enzymes to create viral proteins. And this is the end of this cycle here. And this positive sense RNA on this side of the cell will then again be used by RNA-dependent RNA polymerase to create negative strand copies. And since this is the original form, the negative strand copies will join with the viral proteins, and this concludes the replication of a negative sense single-stranded RNA virus. When we're looking at a positive sense single-stranded RNA virus, things are a little bit somewhat more complicated. As I mentioned, there are two strands of RNA. There's a positive and a negative sense, and you can only make the other copy with the RNA-dependent RNA polymerase. But as you can see, this positive sense single-stranded RNA virus is not carrying any enzymes with it inside of its viral capsid. So once it gets into the cell, there is no RNA-dependent RNA polymerase, and it cannot go through this pathway at this point. But it can create viral proteins because a positive sense mRNA or RNA virus serves just like mRNA in our body. It can be used directly by host ribosomes to create viral proteins. One of the viral proteins that it creates is RNA-dependent RNA polymerase. So once it has gone through our ribosomes, has created a copy of RNA-dependent RNA polymerase, it can then be replicated into a negative sense single-stranded RNA right here. Then once again, replicated by RNA-dependent RNA polymerase into multiple copies of the positive sense single-stranded RNA. Because this is exactly how it came into the cell, it can join with the viral proteins and conclude its replication here as well. So I have a chart here that kind of briefly summarizes what we just talked about. When we're looking at a positive sense single-stranded RNA, which is shown here in the red box, versus a negative sense single-stranded RNA virus, the positive sense single-stranded RNA viruses do not need to carry anything with them when they go into the cell. A negative sense single-stranded RNA virus always has to have an RNA-dependent RNA polymerase with it inside of its virion. And this becomes important when we're looking at medications that might be able to treat these viruses and finding medication target sites. So in comparison to other RNA viruses, what is unique about this positive sense single-stranded viruses? And for time, I'll just kind of show my answer here. So again, we just talked about it, but the uniqueness of a positive sense single-stranded RNA virus is that they don't have to carry any enzymes with them inside of their virion. So now I want to talk about viral mutations real fast. There's a difference between antigenic drift and antigenic shift. Antigenic drift is when there are small changes within the genes of the virus and may lead to surface protein changes. And these changes, they may lead to host immune systems that are going to respond to those viruses, though maybe not as well as they would if they had seen the virus before. An antigenic drift example would be the seasonal influenza, where each year does get a little bit different, but it is likely very close to the same virus. Antigenic shift happens when there's an abrupt or major change within the genes of the virus that may lead to the creation of new surface proteins and a new viral subtype. After antigenic shift happens, many people may not have any immunity against the new virus. To visually show this, what is thought to have happened in the H1N1 2009 swine flu epidemic is that a swine flu and a human flu infected a pig in the same species or the same animal. They infected the same cell, and then in that cell, the genes were able to rearrange themselves and come up with new combinations that represented new viruses. Antigenic shift happens it's not uncommon for it to happen. It happened in 1918 with Spanish flu, 2009 with swine flu, and then this current SARS-CoV-2 COVID-19 virus is thought to have been created through an antigenic shift. Because we went over through a lot of science just now, I want to do a quick summary of the coronavirus. It belongs to the family Neoviralis. It is a positive sense single-stranded RNA virus. It's thought to have a reservoir in bats, and it's transmitted through respiratory droplets. This is an actual picture of the coronavirus, identifiable by having club-shaped spikes that resemble solar coronas coming out of the cell membrane, or the virion of the virus. Some potential treatment options for this virus include hydroxychloroquine, zinc, tocilizumab, and remdesivir. As we all know, the agents for treatment in this virus are changing near daily. And so I tried to keep these slides as most up to date as possible, but there are bound to be a few changes from when I created these slides. So hydroxychloroquine does have a few potential mechanisms of action. As an immunomodulator, it may have a role in suppressing the cytokine storm that often follows a SARS-CoV-2 infection. It has also been shown to inhibit the glycosylation of ACE2, which may reduce the binding efficiency between ACE2 and the spike protein on the SARS-CoV-2 virus. And then lastly, hydroxychloroquine is thought to increase the pH of intracellular lysosomes. The virus gets into the cell through these lysosomes, so by increasing the pH, it prevents protease activity and inhibits viral fusion, or is thought to. The standard dosing of this is 400 milligrams twice daily on day 1, and then 200 milligrams twice daily on days 2 through 5. Now, after I made these slides, 2 studies came out, I believe, in the last week that have not had as much favorable information on the use of hydroxychloroquine. So I'd like to quickly go over these trials. This one came out in China. It's an open label, multi-center randomized trial. It had 150 patients within 16 different treatment centers in China that had mild to moderate disease. They were looking for the negative PCR conversion of SARS-CoV-2 within 28 days and an alleviation of clinical symptoms. And whereas our dose of hydroxychloroquine is fairly low, they use hydroxychloroquine 1,200 milligrams times 3 days, and then 800 milligrams for 2 to 3 weeks, plus standard of care, and compared that to just standard of care. So their doses were much higher than we've been using here in this hospital, and they looked for, again, that negative PCR conversion at day 28. They found that with hydroxychloroquine, there was an 84.5% negative conversion versus the standard of care, which had 81.3% negative conversion, and was not, or it was statistically significant for having no difference. The study did find that although there was no significance for using hydroxychloroquine in the negative PCR conversion, there was a reduction in inflammatory markers such as CRP, and so this may have some use in preventing disease progression, but likely not in the treatment of SARS-CoV-2. Another study came out, I believe, 3 days ago. This study came from the VA. It's a retrospective cohort study of 368 hospitalized patients with confirmed COVID-19. They were looking for death or the necessity of mechanical ventilation in patients that have received hydroxychloroquine plus azithromycin, or just a standard of care. They found that the rates of death or mortality were actually higher in the hydroxychloroquine group alone versus the combination group and the no therapy group, and there were no difference in the rates of ventilation among these patients. They concluded that although this was a pre-printed study and has not been peer-reviewed at this point in time, their findings really illustrate the importance of waiting for a prospective randomized controlled trial before deciding to use an agent. I'd like to also talk about some effects of hydroxychloroquine because we have seen so much use here in our hospital. Some of the warnings are cardiovascular effects, specifically cardiomyopathy resulting in cardiac failure and QTc prolongation. Now, for a while, hydroxychloroquine was used in combination with azithromycin, which can also prolong the QT. And so in these patients that are going to be using hydroxychloroquine, it's really important to look into their history and see if they have any kind of cardiac history, specifically a history of arrhythmias. If there is, it's always important to bring that up to the provider and monitor that QT and make sure that they're aware. Hydroxychloroquine also has a warning for retinal toxicity that is potentially irreversible. Although the retinal toxicity does happen over long-term use, and that's usually after about 5 years of long-term use, which we are not going to be seeing here in our COVID-19 infections. Hydroxychloroquine has been detected in the fetal cord blood, but adverse outcomes haven't been associated with low doses. And it is only available as a PO option. If you have the film-coated tablets, we cannot crush that. Though here at Stony Brook University, we do have a suspension already created for the hydroxychloroquine. So this slide I added, I believe, today. True or false, hydroxychloroquine is currently recommended at Stony Brook for the treatment of SARS-CoV-2. All right, and I may have given that away just now, but hydroxychloroquine is no longer recommended for treatment of SARS-CoV-2. That came out in the update, I believe, on Monday, maybe Sunday, that we had received information that hydroxychloroquine is no longer part of the treatment guideline for the SARS-CoV-2 infections. The next agent I'd like to look at is zinc real fast. Zinc has been used in these infections based off a study that was performed in vitro. Zinc was actually shown to interfere with the SARS-CoV-2 viral replication. So here in this picture, we have the amount of viral RNA that was found. As you see increasing concentrations of zinc, the amount of viral RNA did decrease. Zinc was shown to inhibit the RNA-dependent RNA polymerase enzyme ability to bind to the viral genome. Now, zinc levels are regulated pretty tightly within our cells by metallothioneins, and so it's hard to get zinc inside of the cells. But in a separate study, chloroquine and hydroxychloroquine were actually found to be a zinc ionophore. This means that these medications bring zinc into the cell with them, and that's why zinc has been used more commonly in these patients. Next medication I'd like to look at is tocilizumab. As we may have mentioned, in COVID-19, a lot of these patients in severe disease are developing a cytokine storm, and we see elevated IL-6 levels along with fever that may not be caused by an infection. Tocilizumab is an IL-6 antagonist at both soluble and membrane-bound receptors, and the original Chinese study dosed it at 400 milligrams for a one-time dose, repeating in 12 hours if there was still a fever. Now, tocilizumab has been studied in the past in CAR T therapy for cytokine storm at 8 milligrams per kilogram, a max of 800 milligrams times one dose. And the current clinical trials that are being done on tocilizumab, majority of them are using this 8 milligram per kilogram dosing. And so the exact dosing isn't for sure hasn't been quantified for tocilizumab, but it looks like it likely would be this 8 milligram per kilogram dosing. This is the original Chinese study that did look at the use of tocilizumab. It was a retrospective study of 21 patients looking at the clinical outcomes of these patients. They noted that clinical symptoms did improve in all the patients and that tocilizumab is an effective treatment option. But again, there were only 25 patients, and this was a retrospective observational study, so they only reported descriptive statistics. For time, I won't go through the entire study, but this study is available in a full journal club critique. If you'd like to visit the YouTube channel below, this is the Stony Brook Residency YouTube channel. We have there are 3 journal clubs at this point and 2 CEs. If you would ever like to go any information or any of the things that we are doing in the residence, we're going to try and put them up on this YouTube page. Just copy and paste this link here, and we should have those journal clubs and the CEs up there. Tocilizumab does have black box warnings. The 2 black box warnings are for serious and potentially fatal infections, including pneumonia, UTI, gastroenteritis, diverticulitis, and sepsis, and then tuberculosis, new infections, and a reinfection. So it's always important to assess the patient for any signs or symptoms of infection, and then to assess the patient for any, or test the patient for latent tuberculosis before we do give tocilizumab. Remdesivir is a drug that has received a lot of attention lately. This was created by Gilead Pharmaceuticals in response to the Ebola outbreak in 2018. It's a competitive adenosine analog that inhibits RNA-dependent RNA polymerase and terminates that RNA synthesis. It's dosed at 200 milligrams IV on day 1, then 100 milligram IV on days for 4 to 9 days following that. This is an investigational drug. And so there was a study posted. It was the compassionate use for remdesivir. This evaluated 61 patients using remdesivir, and they reported that while average mortality was between 17 and 78%, on remdesivir, the mortality rate was only about 18% and 13% on those not mechanically ventilated. So they did have really promising results. Now, something that has come up, I saw yesterday, I believe yesterday for about an hour, one of the clinical studies for remdesivir was leaked online. Those results did seem to vary a little bit from what they found in this study here, but the official results from one of the clinical trials for remdesivir should be coming out within the next day or 2, so that will be very interesting to see how this medication will be used in the future. Now, in COVID-19, we often see many complications, and aside from just the treatment, there are many things that go along with it, such as anticoagulation, that there have been questions about, and things have been brought up. I don't have time to go through all of those, such as steroid use or the recent use of an H2RA in treatment. But I wanted to focus mainly on these 2 therapies, ACE-ARB therapies and anticoagulation, because I do see those come up fairly commonly here at Stony Brook. So for ACE-ARB therapies, the SARS-CoV-2 viral spike protein does first bind to ACE2 in circulation. Once ACE2 has been bound to the viral surface to the virus, it can bind to a membrane-bound ACE2 receptor and enter inside the cell. After endocytosis, the membrane-bound ACE2 receptors are downregulated, and this may lead to higher amounts of angiotensin II in circulation, which may lead to enhanced viral entry mechanisms. And so that's why there is so much skepticism around using ACE and ARB therapies at this time, because it's thought that they may lead to an increased entry mechanism for the virus. But it's important to look at all the organizations that recommend continuing using ACE and ARB therapies as we would in normal practice. I don't want to read through them all, but they are listed here. There's quite a few number ranging from organizations in Europe to those in Spain, from Canada and to the United States that all recommend that at this time we continue using ACE and ARBs as we would in normal practice. Anticoagulation also has changed quite a bit. The reasoning isn't exactly known, but many patients with COVID-19 have elevations in fibrinogen, D-dimer, and a prolonged PT interval. These findings are pretty consistent with the hypothesis that severe COVID-19 patients may be entering into a hypercoagulable state of DIC. And as of 4/17/20 in the treatment protocol, there are some recommendations for anticoagulant dosing. It's important to note that no dosing studies on the correct anticoagulation have been performed in COVID-19 patients to date, and all this data is really coming from clinical expertise. So low molecular weight heparin is preferred in all of our PUI and COVID positive patients, as we'd like to decrease nursing exposure to the virus as much as possible. When the D-dimer is elevated over 3,000, that's when we switch to a heparin drip. And this is because it's faster to reverse heparin in the event that there is a hemorrhage at some point. For patients with a D-dimer over 3,000, we do give them 2 weeks of Lovenox on discharge, and then schedule an ultrasound in 2 weeks. If the ultrasound is negative, we can DC the Lovenox. If it is positive, we need to continue the Lovenox for 3 months. For patients with a D-dimer, for patients with a D-dimer of over 1,000, we do need to discharge these patients on 3 weeks of rivaroxaban 20 milligrams a day. And if their D-dimer is over 500, we do need to discharge them on 3 weeks of rivaroxaban 10 milligrams a day. Now, these D-dimer levels should be taken within 24 hours of discharge, so be looking for that when patients are discharging from the hospital. I'd also like to switch and talk at this point about some of the safety behind medication therapies in these trying times and when new viruses and new diseases are created. So what does it mean to have an FDA approval? An FDA approval means the FDA has conducted evaluations of benefits, risks for given indications. There's strong scientific data that supports that efficacy in that indication, and there's labeling that will help guide our dosing for that medication. But if a medication does not have an FDA approval for a given indication, that does not mean that it is unsafe or ineffective. So the FDA concedes that there is safety in using off-label drugs, and using a drug off-label may be beneficial in a new or rare medical condition such as COVID-19. But it is extremely important that we continue to critically evaluate the ongoing literature and evaluate all of that literature for safety and efficacy. We need to weigh the risks and benefits to our drug combinations before administration. So in general, we have to be careful. Most of the drugs we are using in COVID-19 have been around for quite a while, so we do know their safety profiles, but we always should be weighing the risk versus potential benefits for each medication. And to do that, it's really important that us as healthcare professionals are constantly critically evaluating the literature. I know this is hard to do, especially in COVID-19, because that literature changes what seems like daily, but we do need to do our best to keep on top of that literature. So a pandemic is simply an epidemic occurring worldwide, or the occurrence of an illness that is in excess of normal expectancy. Pandemics happen fairly often, somewhat every 25 years or so. There is a pandemic. Many of them are influenza viruses, but there have been other pandemics as well, such as the AIDS epidemic. CDC suggests during a pandemic, one of the ways to help spread or decrease the spread of the virus is to go through social distancing. For the coronavirus, it's important we stay at least 6 feet from other people. That's because respiratory droplets, again, can travel 6 feet. We do not want to gather in groups and stay out of crowded places, which is why we are doing a lot of meetings through Zoom right now. COVID-19 spreads among those in close contact for prolonged periods of time, about 15 minutes or longer, which does seem like quite a bit of time. But if you're having a conversation with a friend, you're probably only going to be 2 feet apart. And if your conversation lasts for about 15 minutes, that's all it would take to spread COVID from one person to the next. So the effects of social distancing can actually be seen. There was a study done that looked at the new cases of coronavirus in the United States before and after social distancing. And so most of our state clampdowns on social distancing happened between March 16th to March 22nd. So they were really being put in place during this period. And once they were in place, we saw a drastic reduction in the time it took to double the new cases of coronavirus. What does flattening the curve mean? A lot of people have been talking about this recently. So the curve, when we're speaking about it in this context, represents a projected number of people that are going to contract the disease, specifically COVID-19. Now, this curve can take on a lot of different shapes depending on the disease characteristics, and that is going to be on disease infectivity, its mortality. It can be steeper or lower. But a flatter curve does not mean that less people are going to become infected. So flattening the curve by social distancing doesn't mean that we're going to have less people overall become infected. It really refers to getting infected over a longer period of time. And that's what we're looking for. If infections happen over a longer period of time, this often means that there's less stress on our healthcare system, and there will be hospital beds available when those patients do become sick. And so in this graph here, this is the original graph that touted about flattening the curve. In red, we see infection estimations without an intervention. In green, we have our estimations when we enact social distancing. And then in blue, we have social distancing that was followed by a premature lifting of these interventions. And so if we do lift the social distancing too early, we may see another peak of the virus come back. Some of the things we can do in the hospital to help out with the COVID-19 response are through antibiotic stewardship. We can support evaluation efforts, develop treatment protocols, and assist in managing drug shortages, as Dr. Monteforti has done here at Stony Brook University. About a third of hospitals do note direct involvement from antibiotic stewardship programs, and so it's great to see that we have been involving our antibiotic stewardship program as well in our COVID-19 response. Some other things that everybody can be doing here at Stony Brook University Hospital, it's really important that we pay attention to the missing medications position in the main pharmacy. And so a lot of our multi-use items such as insulin or albuterol may be requested every 3 days or multiple times within a week, when we know that those items should be lasting much longer than that. And so it's really important that we not simply give out our medication when they're not needed, because we can't always reuse that medication. And to avoid shortages, that missing medication position becomes really important. So now I'd like to play a game here as we come to the conclusion of our presentation. What's the difference? So we have a cloth mask, a surgical mask, and we have an N95 respirator. So which mask will help protect other individuals, people not wearing the mask, from getting infected? 1, 2, or 3? All of them, perfect. So the answer is all of them. All of these masks are going to help protect other people from being infected. Which mask will help protect the wearer from potential infection? 1, 2, or 3? 2 and 3, perfect. So these cloth masks, as great as they are, do not actually protect the wearer from infection. They simply protect other people. PPE masks, the surgical masks and the N95s, will provide some sort of protection for the wearer. And which mask offers the greatest protection? 1, 2, or 3? And that's going to be 3, the N95 mask. So I put together a little graph here looking at the differences between them. Most of them are in this purpose section here. Cloth masks may reduce transmission by the wearer, but they are not proven to provide protection. Whereas surgical masks provide the wearer protection against large droplets, and N95s provide the wearer protection against large droplets and small particle aerosols. N95 masks are the only masks that do need a fit testing. The downside of these surgical masks and N95s is often they do need to be discarded after makeup or after becoming dirty, and they are in limited supply. Is PPE necessary? There was a study that I don't want to go through entirely, but it did show that masks may not be effective in preventing viral transmission to petri dishes, and the U.S. Surgeon General actually warned that masks may increase the risk of infection. So it's important to remember that a lot of these PPE materials, so whether it's mask or gloves, they can provide a lot of protection, but it's really important that we are using them correctly. So I know we're getting towards the end of our time here, but I have some quick short videos that go over how to use these PPE products correctly.
Important thing with regards to PPE is making sure that what you're wearing is appropriate. So really common protective equipment would be gloves. When you're wearing your gloves, the key thing to remember is you should act the same way as if you weren't wearing them, because the virus could still technically through the pores in the gloves. Replacing gloves frequently as well if they do become soiled. That's the key things to remember. This is your common or garden surgical mask. Now this one has ear loops, other ones will tie up around the back of the neck, but they both have the same basic concept for actually wearing them. So you put it over your face. You pinch the wire at the very, very top so it fits snugly to your nose, and you make sure it's coming underneath your chin. The key things to remember when you're wearing gloves and a mask are: don't touch anything with your contaminated gloves that you'll be touching later on without your gloves. Don't put your hand into your pocket and take your phone out. Bad idea. Don't touch your face when you've got your mask on. It's very, very tempting to try and adjust it, maybe pull it down, maybe try and pinch the nose again. But as soon as you touch your mask, you're at risk of contaminating your hands and then contaminating yourself. Now, masks are annoying regardless of how well you've fitted them. But if you fit it correctly, then you should be able to wear it for several hours without it being too much of a problem. One thing you definitely shouldn't do with your mask, which you will see a lot of people do, is pull it from the front. That's the contaminated area. You see people doing this, and then they wear it under here for maybe an hour or two. Absolutely not. Once it's come off of your nose and your mouth, straight into the bin. Same with the gloves. As soon as you touch something which is contaminated, if you're then going to go and use a computer, or if you're going to go and touch something which could not be contaminated, take the gloves off. So the mask comes off, and the gloves come off, and you wash your hands. Very, very important.
Hey everyone, it's Sarah with RegisteredNurseRN.com, and in this video I'm going to show you how to don and doff an N95 mask, also called a respirator. So to don the mask, you're going to take the mask and cup it in your hand, letting the straps dangle slightly. Then you're going to take the mask and cup it around your nose and your mouth, just like this. Then you're going to take the top part of the mask and form it around the bridge of your nose. Then you're going to take the top strap of the mask and put it at the top of the head. Then take the bottom strap and pull it to the base of the neck so it rests at the bottom of your neck like so. After that, make sure that the mask is tucked underneath your chin, and again the clip is formed around your nose, and perform a seal check by blowing and seeing if you feel any air leakage up at the top or at the bottom of your mask. Okay, now whenever you're ready to doff the mask, what you're going to do is you're going to take both of your fingers and you're going to remove the bottom strap first and slightly lean your head forward. So remove the bottom strap slowly but carefully, being careful not to touch the front of the mask because it's contaminated. Then you're going to remove the top strap like so, and then discard your mask. Okay, so that wraps up this video on how to don and doff an N95 mask. Thank you.
All right. And so with that presentation on how to correctly wear your PPE, I'd like to open up the floor for any questions. If there are any questions, feel free to either use the group chat or feel free to unmute yourself. You should be able to do that by clicking on Manage Participants and just unmuting yourself real quick, and I'd be happy to answer any questions that may come up, or try to at least. All right, and it doesn't seem like there are any questions at this time. So throughout the presentation, I believe that both Maura and Brona may have sent out an email with these slides that were attached to that presentation. The email also should have the link to for the pharmacists and technicians, both to a SurveyMonkey. Please complete the SurveyMonkey within 2 months of this presentation. Once the SurveyMonkey has been completed, I'll take a look and I can send out the CE code to anybody. I will try and look at the SurveyMonkey about once every 24 hours and update those individuals and give the CE codes out once I see that the SurveyMonkey has been completed. The SurveyMonkey, give me 1 second, actually, let me stop this recording.